My full name is Thomas John Morrison III, MD. I'm a neurosurgeon by training. I trained at Northwestern University in Chicago and practice in Atlanta, Georgia now. I only specialize in the treatment of spine. Most people present with what we'll call axial back pain, but that's just pain across their low back. A lot of patients will get some radiation of that pain through their buttocks and into their posterior thighs is really common. A lot of patients obviously present with back pain, and there's multiple different options to treat them. All surgeons generally start with the most conservative measures first, and that involves giving patient trial of physical therapy, trying some injections, and that care normally takes a couple months to go through, and you see whether the patient resolves their symptoms. If that fails, then you start looking at different options. Some of those are regenerative. The traditional things that we would do is to start looking at surgery. Some of those surgeries, if we can do them, they're small and minimally invasive, easy to recover from, they make a lot of sense. The problem is when we get into the surgeries that take care of axial back pain, which is the biggest problem, is that they are more invasive surgeries that are normally based around fusion or arthroplasty, and more commonly fusion. So these surgeries come with significant risk. They're all a very small percentage chance, but they're real problems. A lot of common procedures that are done for fusions are done through an anterior approach. So we go through your abdomen, and there's some major blood vessels there, and there are also some important nerves that can affect sexual function. So those are two risks that you have to be willing to take in order to have that procedure done to try to solve your back pain. There's also surgeries where we go from a posterior approach through your back, and you do not have the vasculature risk, the risk to injury of the blood vessels, but you have a little bit more risk to the neural tissue, so that can sometimes cause pain. And also, whether you do an anterior or a posterior procedure, you now have changed the biomechanics of the spine. And when you do that, that affects the other disc or other joints in your spine in a negative manner. I took a strong interest in regenerative medicine to see if we could get people better so they didn't have to have that fusion in the first place, so then they never come see me in the second place, right? After they have the first surgery not go well. And since my practice is basically getting referrals from other surgeons and goes very well, I thought, hey, it would be nice to see if we can help some of these patients before they get stuck in a bad situation with surgery. So in our case, if a patient clearly has facet joint related pain, we will just inject their facet. But most patients that have low back pain have a component of disc degeneration and pain coming from the disc. In our experience, the risk is extremely small with the biologics. So most of the times we're using your own body and concentrating mechanisms in your own body to help your own body heal itself. So the risk in the regenerative therapies is exceedingly small, whereas the risk in an open surgery may be a few percent of having a significant complication and maybe a success of 60–70%. The regenerative, we've had no complications to date, and we have about the same success, around 70%, so much better odds for the patient. If you have the wherewithal to go through the regenerative procedure financially, we recommend that you strongly consider it before you jump into having a much bigger open surgery, because your risks are exceedingly low, and if it doesn't work, you can always go on to have the larger surgery if you choose. In our case, we do it as a single injection, and we normally use lipogyms. Occasionally we'll use PRP, and we can get into all the details of those two, but lipogyms is the workhorse in our facility, and we've seen the best results with it. So a patient would come in that day, get some mild sedation. We'd harvest just a tiny bit of fat from a little needle stick. Then we would inject it into the injured joint in the back, the disc and the facets. A patient would experience a little bit of pain that maybe rev up their system pain-wise for about 5 to 7 days. Then it normally settles down and they're back to where they are. They just do that one injection, that's it. We tell the patients to take it easy for the first week or two as they, just recover a little bit. But then after that, we let them go back to their full activities and don't put any restrictions specifically on them. And then they have to give it some time. We see patients are getting a lot better at about 3 months, and then even better at 6, and even a little bit better out to a year. So they improve for a period of time, and I think that that's one of the important things. These cells that we put in don't necessarily work instantly, but you have to give them a little bit of time to see the success. The thought is by putting these biologics in there, the disc will heal and repair itself some, and then that will get rid of the back pain over time, and then they'll stay away from having to have major surgery.